today we are starting for the session SLR and MA in medical research. So my point is what SLR and MA and why it is required. We will start with these things, then we proceed in the in-depths of the things. So I will quote an example for the beauty of this SLR MA and why it is needed. For example, uh, you you are a clinician or you are a evidence synthesis manager in some corporate, and you want to find like whether a drug A or drug B is better for the epilepsy. Just for sake of example, I'm just giving this example. So what approach you can opt for this, like whether drug A or drug B is better. You can uh, put it in chat box so that I can see the chat box in the latter part. So Dr. Shakil, they can answer the through voice or they can chat only.
Yeah, they can unmute yourself as well, and they can put in chat
Okay.
whatever they will be.
Okay. So anyone can try wants to answer these questions, like what the approach, if you are a doctor or a clinician, what approach do you find to find the things like drug A is better than drug B? Anyone?
No, sir.
Okay, no issue. That's why I'm here. So we will start. First of the things, like if you approach a doctor, so doctor will himself, like for his personal experience, what he gained during his course of treatment or practice, he will say like for drug A, this age group or this type of patients are more suitable. So this is one approach. Clinicians or doctors can answer this thing through their personal experience. Second, what they can do, they consult their fellow doctors. They can ask themselves in the group. They can ask like, okay, which drug is better according to all of you. They can give certain, okay, drug A is better. If they vote themselves like drug A is better, this is one of the approach. And third approach they can do is they search for the published literature, what literature published on this behalf, like RCTs, observational studies. So they, on these three bases, they can find the evidence like which drug is better. But every in these three methods, they have certain limitations. For example, a drug, like a clinician himself, he is biased with like a specific type of population, or he has gained like only he is working only on a specific population like pediatric. He can't say that okay, for adults this type of drugs is better or not. And second case, when they do the expert discussion, there might be chances that one single senior expert might dominate the chat, and they say that okay, drug A is better than B. So these, and in the third case, like literature can be published or they have taken a specific population for a specific area, so they can't be broadly generalized. These are the few limitations on the basis of which the advent of systematic review and meta-analysis started. So this is the requirement for the systematic review and meta-analysis. So before starting the systematic review and meta-analysis, we need to find where this SRMA sits on the evidence table. So on the lowest level, it is animal research, like when we are doing clinical molecule finding, or like in rat study, or whether the drug is working on rat or animal models or not. Then above it, it is expert opinion, as we have discussed. Then in the case series, or for a simple few patients, like 10 to 15 patients or 20 patients, then above it, it is observational studies, uh, non-randomized trial, and then we go for the randomized trial. Earlier, before that SRMA was famous, the topmost is the randomized control trial. But with the advent of systematic reviews and meta-analysis, it sits on the top of the evidence table. So it is very crucial to understand this systematic review and meta-analysis. So hope till now there is no issue with these things. These are all basic. So why systematic reviews is needed? So we have already discussed, like for example, we have a study on epilepsy. I will give you most of the examples with the epilepsy, as my area of disease is epilepsy. So I will give simple examples. For example, study A said epilepsy is well treated with hormonal therapy like ACTH. It is well treated. Study 2 said, okay, yeah, it is well treated. But study 3 said, okay, it is approx equivalent to the placebo. Placebo, or like if we give no treatment also, its efficacy is similar to this study. So what evidence we can say, like for example, study 3 have used huge number of, means large population. Study 2 have used 100 to 200 population, and study 1 has used only 50 population. So these are the drawbacks, means where we need to focus while conducting the systematic reviews. Okay, so here what we have understand, study 1 and study 2 say that ACTH is best suited for the treatment of epilepsy, but study 3 on the large population say like it is not as good as previous two studies has said. So what clinician will do, what evidence they will generate in the final thing. So what here the systematic review and meta-analysis comes in the role. What they do on the basis of that effect size, or like what the population they have used. Okay, on the basis of it, it assigns certain weight to every study. Like we say na, like for example, we have we had a one murder in our locality. We have a few suspect eyewitness. Like one is already one criminal, other is a lawyer, other one is a boy, children. So all were asked for like what have you seen the the scenario of murder. So whose weightage will be given according to the your idea. So definitely the person who is lawyer, who is well versed with the society, so his what you call his verdict will be more weightage. So like this only, we have certain criteria for doing the appraisal of the studies, and on the basis of this, we give weightage to every study. We can't like uh, in the previous example, if children, he might say that okay, he had seen, he might say yes, he might say no according to his mental ability, but we can't rule it out there what their verdict is. We have to use all the patient's verdict and combine it. Okay, so then we can see that what exactly the murder who has done the thing. So similarly, the case is it with meta-analysis. We, whether the study is good or bad, we extract all the things, we critically appraise the things, and do the pooling, and then find what the average, what the uh, pooled average say about the evidence. For example, when we pooled all the three studies, what they have means in the study, and we got that okay, according to population size, the ACTH is not as good as this. So this will be our final verdict. So this is just an example how we approach for the systematic review and meta-analysis. So recently here, this is data I have pulled from till 2019. So I have found like in the recent years, there is boom in doing the meta-analysis and SRMA. So like we don't get the FOMO. So you need to learn these SLRMA and insights of this SLRMA, because most of the nowadays corporate and evidence like DHR and other institutions have started doing meta-analysis and system reviews for generating evidence. As we know, like RCT is doing simple RCTs cost a lot, and time is also required, very like a large amount of time is also required. So like recent here, for to avoid this like misuse or overuse of the resources, and government of India also started investing more on the systematic review and meta-analysis, like through Department of Evidence Generation in under DHR. So I am also working under this DHR for Department of Health and Research. So we can see like approx daily 3 to 4 meta-analyses were publishing globally. So, so now we will start with the steps in this SRMA. What steps we will follow? There are specific fixed step we need to follow. See, systemic review, we don't need to go to any hospital. We don't need to go to take any sample or take any population. So one thing what required in the systemic review is transparent reporting, and everything must be documented. This is the sole heart of a systematic review and meta-analysis. So everything must be documented. So the first step before starting a meta-analysis, we have to uh, register the protocol. Means what we are going to do, that is we can sometime we can do in another session how to register our protocol. So first step in the systematic review and meta-analysis is to register the protocol. What approach, what outcome we are taking, what type of inclusion and exclusion criteria we are maintaining throughout our study. This must be uh, registered as a protocol in different databases that we can see in next sessions or in upcoming sessions. The most commonly used registry for systematic review meta-analysis is Prospero, OSF, this type of registry. And it is compulsory to register your systematic review and meta-analysis before proceeding to the next steps. We need to register it. Okay. And why it is required? Because everything must be transparent, everything must be reported before conducting, so that in the later stage, the reporting bias uh, is not happened in our systematic review and meta-analysis. What is this, reporting bias? Anyone can say? If anyone has any idea of reporting bias. Okay, I will, because we have a limited time, so I will explain that reporting bias. Reporting bias means sometimes what to happen, na, like some company is doing meta-analysis. For example, Sun Pharma or XYZ company is doing some, they have generated some drugs and they want to do SRMA of the, like with the, compared to the already well-versed drugs. So they're comparing and they found like, okay, in the efficacy, it is better. But on the basis of safety profile means adverse event, it is not good. It is not, means it is getting, we are getting more of the adverse events with the new drug as compared to already established drug, but the efficacy is higher. So what these companies or any like person who has like direct connection with that drug. So what he can do, he can publish the result of that efficacy of the drug, but not of the safety profile. That how many, what is the difference between the uh, uh, adverse event or any mortality rate is there or not. So these type of things we need to avoid, so that whatever the drugs, the transparently we can present the results. So first of the things we need to do in the systematic review meta-analysis is the sorry. First thing we need to do is uh, register the protocol. First and foremost thing we need to do. Then second, we need to do with define the PICO format. PICO format we will study in the next upcoming slides. So PICO format required for making the search strategy. Search strategy is the first step, officially first step in conducting the systematic review meta-analysis. As strong as your search strategy, your meta-analysis or your evidence generation is as much good. For example, I will give you a simple example. Imagine evidence as an ocean, and sorry, this world as an ocean, and evidence was distributed over all the in this world. So we want to catch all the evidence present in this world. So like count evidence as a fish. So we need a big net as and well means what you call good net, so that it can capture all the available fish in that area, what we can consume. So for this reason, we need to make the search strategy very good, very proficient, so that it can capture all the available evidence in that area. Then we need to do the study selection, that is known as screening. We had a two step in the screening. First step is TIAB screening. TIAB screening we do on the basis of title and abstract. Second is on the basis of full text. So, like for example, we have got after the search strategy, we will conduct I will show you the how we can do the search strategy. After getting the search strategy on PubMed, we have got approx 200 articles. In the 200 articles, we they not might be related to our research question, what we are trying to do, like drug A versus B is better in case of epilepsy. There are a few articles might be like A versus C is better, which one is better, or the population might be different. So we need to first check the title and abstract only, whether it might be suited or not. If it is, if we are unsure on the basis of title and abstract, we need to write unsure, and then we proceed for the full text screening. Okay. Then we have to do the full text screening. This is very crucial stage. We have to see every article what we have done after the primary screening, that is full title abstract screening. We have to check relevantly whether it is suited for our PCOs. PCOs I will explain in the later slides. Then we go for the data extraction. Data extraction is a data extraction we usually do in the Excel sheet. What points are required or what evidence we need to generate is noted or extracted in that data extraction sheet. We do the piloting of that data extraction sheet, and afterwards we do the quality assessment. We have different tools for the quality assessment for different study designs. We will also proceed in the further slides. Then we do the meta-analysis. Meta-analysis, we have few softwares available like R Studio. It is freely available. Rebman, earlier it was freely available, but now it is paid, subscription based. CMA also, it is freely available. Excel we can do, but people avoid doing on this. So these are the databases, like where we can find the fishes. We have to go to the ocean. Likewise, where we can find the relevant studies. We have different medical databases, like PubMed, Google Scholar, PsycInfo, Cochrane Library, Embase, Web of Science, Ovid, Sinhal. These are the few databases. There are more, but I just focus on the health related databases. Okay. So what we see in the like PubMed side, all are freely available. What we are seeing in the Embase side, all are paid. We have to pay or subscribe to the institution. So we usually go on the, like, if you are starting or piloting any study, just start with the PubMed, and the Cochrane library is freely available up to certain stage, but we can't download the articles from it. So you can use for just reference, but PubMed is freely available. So this we have already discussed. We have to formulate the research question, select the databases, develop search strategy, verify the databases, and then run the search and screen and selection. These are the steps we have already discussed. Now, search strategy. We follow two type of search strategy. For defining, for creating the search strategy, we follow two framework. One is PICO or PICOT or PICOS, and other is PEO. PICOT means P stand for population, P stand for population. For example, I am searching epilepsy patients or pediatric epilepsy or children with epilepsy. My population will be children with epilepsy or pediatric epilepsy. This would be my population. Intervention, like I have said, I for intervention. Intervention means what drugs we are giving or what services we are giving to them. For example, if I am giving ACTH, ACTH as a therapy to pediatric epilepsy patients. So my intervention will be I means intervention. So intervention will be ACTH. Then comparator. In meta-analysis, we have always a comparator. When we are doing interventional meta-analysis, we have always a comparator, because we are checking na ki, this drug is better than what. We have to define what means what might be placebo, what might be usual care, or what might be already established drug. For example, uh, if we are checking ACTH with already established drugs like vigabatrin. Okay, so we are checking if efficacy of ACTH with sorry, what drugs I have told, ACTH with valproate, for example, we are saying. Okay, so we are checking the efficacy of ACTH with the valproate. So these will be our intervention and comparator. Now, third thing is outcome. Outcome is very much important for the clinician's point of view. We are doing systematic review and meta-analysis for clinically defined questions or research questions. So, sorry, wait a second if any questions. I will just check if any questions are there, or if you have any doubts till now, you can put it in chat box so that in between I can take the questions of yours, or otherwise we will take in the later uh, last at the last. Okay. So up to outcome, we have understand. Outcome might be like for epilepsy, we might have seizures. For in epilepsy, we might have seizures. For your other disease, we have like for if you are doing NSAIDs, like NSAIDs as your intervention, you might have headache, you might have fever as a, or you have pain as a outcome. Like what outcome must be reduced with these outcomes. Okay, here for defining the outcome, for comparing two drugs and defining the outcome, there is a clinician's help is needed. So always when you are conducting a systematic meta-analysis, consult any of the clinicians or of the medical background so that they can define which outcome is best suited for these drug efficacy or safety. For example, if I am taking like for epilepsy, I will give you example. In my early days, I am doing systematic meta-analysis, and I have taken outcomes like uh, time taken to seizure reduction. But when I discussed with the clinicians, they said that the major thing what outcome must be defined is seizure reduction or electroclinical remission of spasm. It is a clinical terms. I don't go inside these things, but how they suggest this must what outcomes must be taken as a primary or must be taken as a for our meta-analysis. So this must be done in consult with some clinicians. Then sometimes we stop here, or sometimes we go for the time frame. For example, if we are doing some COVID drugs, means if you are doing some our population is related to COVID or specific diseases which are which happen in a specific time frame, so we can add the time frame also. Like, or for example, if we have time frame of we want to check the outcome in the first 10 hours, so we can add the time frame also. Then we had a study design. S stand for study design. Study design is like we have seen in the evidence synthesis, evidence hierarchy table, that RCTs are at the topmost level. If you are taking observational studies, what we are taking means observational study might influence our results. Like, because why? uh, Observation studies is not what you call uh, critically uh, means done. Like, they have not ideally done according to the like how RCTs are done. Like, for RCTs, everything is documented, everything is pre-planned, but in observational studies we don't do these things. So that's why the outcomes of the observational studies might be inferior to the outcome of the RCTs. So that's why for like our first choice for the including the study in the meta-analysis is RCT. We go for the RCT so that the highest quality of evidence must be generated. If no RCT is available, for example, we are doing some very pediatric patients study where RCT is not possible, we go for the observational studies also. Okay, so these are the few uh, key points we need to take while creating the framework. Now, other framework is PEO framework, where P means population, as we have defined earlier, E means exposure, and O is the outcome. Here, what we do, like population, we have defined, like we will go for the next slide. Huh. So population for population being studies, exposure to the pre-existing condition and outcome of the interest. So these are the like how we can find here what we can do. Like I will give you a simple example of PEO. Like we want to check, investigate the association between publication performance and work environment of university research academics. It is a systemic review. Here what we want to do, like in universities or there now always there is a pressure to publish the paper. So here what exposure we are giving, publication of the paper. So what outcome we are getting, publication performance or depression, this might be other. Okay, as other like outcomes. So these are how we can proceed the systematic review. There's like these type of questions also we can get. So like PCOTS format I have already explained. So this is one example of PCOT format. Like we want to check efficacy and safety of dietary therapies in childhood drug-resistant epilepsy. So here population, we have childhood drug epilepsy patients here. And intervention, we have dietary therapies. Comparator, we have comparator might be like usual care or whatever the other dietary therapies we have already given. Like here, they have given various dietary therapies. Then outcome, safety and efficacy. Here time frame, they are checking only for the 3 months. Like whatever the outcomes we are getting in the first 3 months, we will consider only these. The long-term outcomes like developmental delay due to like mental ability or like quality of life on the long term, we are not taking those things. And study designs, we have taken only RCTs because we try to get the highest quality of the evidence. Okay, so this is how like we need to define our PCOTs so that we can on the basis of PCOTs only we go for the making the search strategy. Okay, so like we have already defined the PCOTs. Now on the basis of PCOTs, we are going to make the search strategy. We make the this is the example of search strategy we have made in the PubMed. Okay, so we start with the population, and population we have epilepsy. So we want to add population like synonyms of the population. Like few people may say epilepsy, some may say refractive epilepsy or Lennox-Gastaut. There's certain synonyms of every disease. So we need to add all the synonyms of that specific disease so that now no evidence can be left out. Okay, so we defined on the basis of PCOTs. Like population we have added, that intervention like we have added ketogenic diet, modified Atkins diets, low glycemic index treatments. Then yeah, comparator. And sometimes now when we define the search strategy, when we are doing the search strategy, we usually go for the population, intervention if comparator is very much crucial. For example, we want to check uh, dietary therapy with the drug therapy. So then here we need to define dietary therapy like ketogenic diets and all, then drug therapy like valproic acid, ACTH. And if we are checking dietary therapy with treatment as usual. So we can skip the comparator part. So here we are doing with the normal treatment as usual. So already they will compare the things. So we skip the comparator part and combine the things. We have got the 1370 articles after screening. Then we will export it to Excel. This 1370 articles we export to Excel, and then we screen it on the basis of title and abstract, then on the basis of full text articles. Then we make the extraction sheet, and then we, on the basis of extraction sheet, then we do the critical appraisal or like quality assessment, and then we do the meta-analysis of the thing. This is the flow of the uh, things. The same, this is how M-based search strategy looks like. So this is, for example, and then when we done with our TIAB screening and all the things, then we go for the Prisma. Prisma is the checklist. It is, if you are doing systematic review meta-analysis, the we need to follow certain rules and regulations, and those rules and regulations were provided by Prisma. Prisma has checklists. Prisma has certain critical appraisal tools also. So Prisma give us the things like how you need to report the your meta-analysis, how you can report the meta-analysis in the best possible way. So here we have screened the everything. So this is, for example, we have one system review meta-analysis. We have done the system review. Then what Prisma want to say to us? This is the thing. So Prisma give this format, like how many databases you have screened. Like for example, in this study, I have screened for 4 databases, like Web of Science, PubMed, Cochrane, and Embase. Okay, so the we have to step by step document all the things, like how many articles you have screened from the databases, and how many you have screened from the other places. Like you have, while you are screening your some articles, you have searched the reference, or you have searched on the Google, you find some more reference related to the article. So so this is how you need to proceed. Then in the screening phase, you have screened on the basis of first title and abstract. Like for example, here 4,385 articles were screened on the basis of title and abstract, and after screening we found like 4,040 articles were not relevant to our PICOs, what we have defined our PICOs or our inclusion criteria. Then we left with only 345 articles. So we screen these 345 articles full text. You have to download the PDF of 345 articles, then document everything about that articles, like why you have excluded those. If you find that after reading the full text that it is not relevant to our PICOs, so you need to document why it is excluded. For example, we have screened full text 345, and out of which reports 336 were not relevant to our PICOs. So we have to document like why 45 articles have different population, what we have defined earlier. 83 articles doesn't define the outcomes, what we have considered as an outcome. They haven't, and then 107 were not RCTs. Okay. So, and 65 were not of the interest interventions what they have given, like we have done for this ACTH, but they have given some other interventions. Okay, they might not be given in the title or abstract, but when we read the full text, they have written, okay, we have taken some other, or they have taken combination therapy. So we need to exclude those articles. And sometimes what happen, like we have limited access. Some articles are published in like embargo. I think embargo you might have know, like is recently published, and they are not. You have to subscribe the things. So as a student or as a individual, we can't afford to pay that much amount of. So we have to document the things, like full text are not available. Ideally, Cochrane, we follow for this systematic review meta-analysis, we follow Cochrane handbook. And in the Cochrane handbook, it is written like if you are if you are writing full text not retrieved, we need to ideally mail twice at the 1 week difference for like to the authors that I want your full text. If somehow he said, okay, I can give, so it will be well and good. And if not, you have to, again, after 7 days, you need to ask them, you have to take the records of this mail to yourself while publishing you can add it in the supplementary file that we have asked twice, but the authors haven't responded. Then only you can write here that full text not retrieved. So I have like mailed 36 like for the 36 authors, and they are at the time period of 7 days, and they haven't responded. So I can right here full text not retrieved. Then from other sources also, what we have got, like from the citation, we have searched the reference of the included studies for the relevant articles. We found 9 studies might be potentially included. Then we again found 5 we can't retrieve due to some reasons. Then 4 of the studies what we have included, we found that population to have population differently mentioned, and outcome of interest is not in. So we finally include 1 more article. So we have got in total of 10 systematic reviews. This is how Prisma flowchart, you need to document everything clearly with how and where, and you have to take every notes, and everything must be uh, and whatever the things report excluded after the full text, you need to make a table like okay, this is the title, serial number, title of the article, and the reason of exclusion for every article. This is well documented. This must be well documented, because most of the uh, good journals like PubMed Index or any good journals, they want these things from you. They expect these things from you to be given along as a supplementary file, because this is very crucial. These things avoid the biasness. Somehow you can skip the things, okay, I don't want to search, but you haven't documented. So you need to document every step. This is the beauty of this systematic review analysis. And this is how extraction sheet, I will not go in depth of the extraction sheet because it will take more of the time. So this is how a well documented extraction sheet looks like. Like we have to document everything social demographic of our included studies, like author name, year, title, DOI, design, what type of design it is, blinding is there or not, what type of interventions they have given, what type of study design, which country they have given. So these things must be documented, so that it, and some like JAMA and Lancet, these type of journals usually ask for this well documented systematic extraction sheet also as a supplementary file. So you have to maintain these things. And this is the example of some incorrect, how we can incorrect extraction sheet looks alike. So there is one rule for the extraction sheet. When we are extracting single information in a single cell, everything must be homogeneous. Everything must be homogeneous. For example, I am saying, giving you example of duration of study in months. We have written in the months, but few studies might have given the 40 in the weeks. Some might be given in the days, some might be given in the months. So what they have done here, they have written as they have things. So we need to transform and make it homogeneous. This is one of the information aspect of extraction sheet, is extraction sheet must be homogeneous. Understand? This is one of the things. Again, when we are checking for the mean age and SD, we found that one study, Barucha et al. Has given mean and SD, but these things have what they have done. They have given mean and range. So we need to convert in SD or any. There are lots of formulas available, or there are more lots of calculators available online. So you can calculate it and make it homogeneous in the extraction sheet. So now extraction we have done. Now the next step, as we are moving ahead. So next step is the quality assessment. Quality assessment, why it is needed? Why quality assessment is needed? Like we are doing, but why it is required in this systematic review meta-analysis? Anyone can unmute yourself and answer. if you know, or any guess also, it will be good. Like it will be good, like we are proceeding in a like right direction.
Like quality gives the good outcome so that complaints may increase in patient outcomes and all.
Means yes, approx. I would like to say 10 to 20% you are on the right track. So yeah, so what happened now? Like sometimes there's misconceptions. Like if it is published, it might be good. There's always like nah, whatever you have done, if it is published means it is good, it is very good. But we have seen many papers are, or recent times lots of papers are retracted every day. Okay, especially from the India, it is now you, I don't know, like I have seen some news recently, like India, the highest number of papers are retracted. Why? Because might be they are not maintaining the quality, or like they might use the inferior way of presenting the results. So for avoiding these things, we need to check the quality. So first, what we have to do, we have to document everything. Second, we have to check the quality. For the checking the quality of our included studies, for example, we have RCTs, so we have certain tools to check the RCTs. So like, for example, we have ROB2 tool. Okay, Cochrane has given us ROB2 tool. So these I have already told. Okay, so these are the examples what we use in the systematic review. Some tools like ROB2 tools for the it is a Cochrane have given these tools. You can find it on the website also. So these only used for the randomized control trials. Then we have JADAD scale. This is also a scale used for the RCTs. Then for observational studies, we have Newcastle Ottawa scale. Okay, then we have STROB checklist to how observational studies are reported on the epidemiology. Then we have CASP checklist. These are the few checklists and tools available online to check the quality of the included studies. So I will just focus on the RCTs. Like we don't have that much time for seeing the all the things. So uh, Cochrane, according the Cochrane, they have in ROB1 tool, they earlier before ROB2 came to scenario, ROB1, we used to get certain points. On the basis of points, we say that okay, this study is good or bad. But these have few flaws, so it has been revised, and now this, yeah, what you call this specific score has been removed, and we just rate it on the basis of like traffic light signals like red, green, and yellow. So these things have been rated on the basis of 5 domains. 5 domains are randomization process. Randomization process means how the randomization were done. Like randomization, I think most of the people knows the randomization process, why randomization process is required, so that to remove the bias. I will not go in depth of these things. So these are the few domains what I'm trying to explain. Then deviation from the intended interventions. I might have time, I will show you, but I think I will go with the specific. I will give you some examples here only, so that in the next step, when we specifically focus on the risk of bias, because it is a whole, like it will take 1 or 2 lectures for assessing the risk of bias. It's a very vast lecture. Okay, so I will just give you examples. For example, randomization was not done. So like I want to check study on ACTH and ACTH efficacy and safety. I have done RCT, and what I have done now, I want to show that our ACTH is very good. So I haven't done the randomization. Whatever the good patients or in the early stage of disease patients are, I'm getting, I just move it to the ACTH stage. And what old people are very in the critical stage, I'm moving it to the another drug, what I want to compare. So obviously, because randomization is not there, blending is not there. So because of these things, now we can manipulate our results. So always, that's why I'm saying like randomization or RCTs are of a good quality is required. So on the basis of first domains, we check the how randomization is done. If it is done well and good, so we rate it good. Okay, green. Then deviation from the intended interventions. This means, for example, I am giving ACTH for the pediatric population as a 50 international unit per day. But what I found, like, okay, the seizure is not stopping in the when I follow it for 1 week. Seizure is not stopping, and what I do as a clinician, I just increase the dose to the 70 or 75 international unit. Okay, so these what we have intended for the intervention, what we have written in the protocol, we have deviated because of the like what you call ADRs or inefficacy. We have changed, or we have done change from the what we have decided to do the intervention. Like for example, we have decided, okay, low dose ACTH we are only giving, but what we have done here, we have turn it to the high dose. Though definitely if drugs are given in a high dose, it will show more efficacy. So it also increase the what you call biasness in our randomized control trial. Then missing outcome. What we have done now, like I will not go in concept of ITT and per protocol, but I will give you some simple example. Like we have recruited 100 patients. We have divided into, randomized it into 50-50 group in ACTH and in a placebo group. But what we have found, like some patients from the ACTH group who are old, or who are from the getting more adverse reaction, they don't want to join the things. So because of these things, what happened, like missing like patients were removed from one group. So what it might show, like we have now get with the healthy patients only, so it might overestimate the results. Like ACTH is very, very good as compared to the placebo. So these are, like, on the basis of these domains, we follow the risk of bias in the included in studies, especially for the RCTs. So if in the future classes, we will go in depth of this domains and ROP2 tool, so that we can go more like the things. And this is how we got the results. This plot is called traffic light plot. Here we can find red if randomization. D1 is the randomization process. If randomization is not good, we will get red if it is clearly. And if we are unsure, or we are we say that okay, randomization is there, but might be chances that due to some reason bias can arise. This we can do in depth in later our upcoming sessions. So this is how our risk of bias traffic light signal will be seen. Now, this is the RCTs. This is the forest plot, how forest plot is visualized in a real life. So this is categorical outcome. Categorical means like either yes or either no. Like it is no in between. Either they are treated, or they are untreated, or the results, either they got effect from the results, or either they haven't treated from the, or they haven't got the effect of the drug. So here, like we have given SCT is stem cell therapy, and control is like placebo group, you can just say. So what we have, for example, Zhao et al, we have total 53 participants in the Zhao group, and there is no avian. Avian is avascular necrosis, like it is a bone disease. So bone disease, or like necrosis of the bone, where bone at the joints got degraded. So we have given stem cell therapy, and we have checked 53 patients, and there we found zero event of avian. And in control, we have given 44 patients, and only one patients have got avascular necrosis. So what we have checked, like so this shows like stem cell therapy is better than the control. Okay, but how much it is better? We can see, look, here 0 and here 1. It might be maybe due to the chances or anything. So that's why you can see, okay, it is showing it is better than uh, control, but what this confidence, this line, like this box is effect estimate, and this line, what whiskers, a long whiskers you are seeing, it is a confidence interval. So confidence interval is crossing the line of null effect. Null effect means this. Here, if anything comes on this, like this article, Hauser et al., it is showing neither control, neither SCT, both are equivalent. So anything comes on these things, it is showing like both the intervention and comparator are similar. So anything comes to the right side. So I will explain the things like how to read the forest plot. So as it is a ratio, and a ratio means 1 divided by 1 always be 1. So our null effect always be on 1. So, and when it comes to the continuous outcome, like we are checking the pain score. Pain score might be 2, 2.5, 3, 3.5. So if you are say like after adding some intervention, so pain decreases from 3 to point of 3 to 4 points. So it is continuous outcome. So here at that time, the central this line of null effect, instead of 1, it would be 0. But as it is a ratio, here you will get 1. Okay. So this how these results come statistically in the upcoming session. We might explain you. Okay, but now you just learn how to read the forest plot. Okay, then you can see boxes and diamonds. Okay, this is the black diamond. This is overall pooled estimate. This is our result, what we are seeing. We have done all these things to find these square, like this total, like last one, a diamond black color. This what we want to search in our result. So we check here, like everything we have checked, we have compared stem cell therapy versus control, and what we found, like diamond is overlapping on the line of null effect. So what it is saying, like, okay, it might be better than the control, but but the heterogeneity is there. Heterogeneity means results might be sometimes good for control, also might be for SAT. It is not so much good. Okay. So here also you are saying that results, it is showing 0.74. How we read this 0.74? Okay, what we do -1. Okay, so 1 minus 0.74, we get 26. So we say like 26% of the chances, like STT is better than the control. So what we are saying, only 26% of the chances are better than the control. And if this comes to this side, what we say, it will come to more than 1. So for example, if it is 1.74, so we will minus it from 1, so we will get 74. So we can say 74% of the chances is that control is better than the stem cell therapy. So this is how we read the forest plot. So after forest plot, we have last step of checking the publication bias. Sometimes what happen now in real scenario, due to publication, the positive results are published, but the negative results are not published. For example, if I would like to say, like I am checking results for ACTH, or I will give you more. Uh, huh. ACTH is better than vigabattin. Okay, so all the studies are showing, like already published studies are showing, like, okay, ACTH is very good than vigabattin. But when I am conducting on a specific population, I found like, okay, vigabattin is better than ACTH. So it is totally opposite. So what will happen now? Like some journals, they say, okay, it is negative, I think you have done something bad, or because of some reason they won't publish, or because I don't have any justification specific to it, it will not see the publication. So for seeing these things, we have to check, like, okay, negatively outcomes were published or not, because it is required as like only if only positive results were published. For example, for ACTH, all studies have said like ACTH is good, ACTH is good, but there is no negative studies. So what we will say when we are doing meta-analysis, we will say, okay, ACTH is very drastic drug for like for epilepsy. So that's why we need to check the publication bias, so that how much confident we are, like, okay, results is based on the both positive and negative results. So for that we have few statistical tests, like adjusted correlation method given by Beck's, and that's why it is known as Beck's test, and other is linear regression method. It is given by Agar, so that's why it is known as Agar's test. You can find on the Google boards of the things. And another method, if you don't want to see the this p-value and don't want to go in depth of the p-values, so you need to check it on the basis of uh, uh, you need to visualize the forest plot. So this is the example of very simple forest plot. So as we go up at the pointed side, so here the highest, like if a study has like very large population, 1 lakh 50,000, 10,000, so it will on the top side of the this funnel. It is called funnel because it is looking as a triangle in an inverted funnel. So that's why we name it as a funnel plot. It is an inverted funnel. You, for your reference or for your remember, you can see that. So whatever the studies which have higher sample size and highest quality, it will be on the top side, and the studies which have lower sample size, it might be on the left. Okay, so you can see that there is one negative and one positive side. So in this forest plot, we are saying that both negative and positive studies were published. Okay, so we can say that, okay, there is no publication bias. If all the studies were on the single side, so we can say, okay, the studies, like the chances of publication bias is very high. So we need to document it. Okay, like all journals want this. So thanks. It is a